Hi, my name is Andrew Collingwood, and I'm recording this slideshow that I gave in 2015, although it's just turned 2017, because I thought it would be interesting to put it online, and it covers a lot of information about bronchodilator response testing, also known as reversibility testing. I'm the lung function manager. I'm a respiratory physiologist at Counties Manukau Health in Auckland, here in sunny New Zealand. So I'm going to be talking as if I were in 2015, although it's a bit after that. I'll try and stay true to what I said in that particular meeting in Queenstown. So I remember at this event 2 years ago, 2013, Brenton Eckhart, who's unfortunately passed away now, telling us to question everything we do, no matter how routine. So in that vein, I'm going to be critiquing the dogma of reversibility testing in about 30 minutes or so. And this is something that lung function laboratory will do routinely, or be asked to do routinely. So just so we're on the same page, this is what I mean by a typical beta agonist response. First of all, we do spirometry, then we get salbutamol into them, and you may critique their inhaler technique while doing so. You wait 10 to 15 minutes, and maybe do some other tests in between, and then do the spirometry again at the end. And why do we get asked to do these tests? What happens to someone's spirometry after a dose of the beta-2 agonist? Well, here are 4 examples from where I work right now. Well, the first of all is one commonly tagged onto spirometry, that is to request to confirm or deny the presence of airflow obstruction, and then to differentiate between COPD and asthma. And I'm sure you're very familiar with a version of this request. Just note the please there. Doctors are always very polite when they ask for tests from the lung function lab. In this next one, here someone thinks it's useful to know what happens to their bronchiectatic patient's spirometry after a dose of salbutamol. One presumes it's to guide treatment. In this case, they want to know if there's any reversibility. Again, that please do salbutamol reversibility testing, very polite. Here in this next referral, they ask for a bronchodilator response in the tick box part, but I've just put the clinical information. Lots of information in this one. This is basically a query asthma one. The referrer has been generous with lots of their recent history. The issue, of course, is when they turn up to do the outpatient spirometry, if they are back to normal without a wheeze when they present, and they have normal spirometry, which was the case here when we tested them. Again, very polite requests. Here in this next one, in this referral, a bronchodilator response is required by the requester in order to know if it's safe to give a beta blocker to this individual, which I assume again is a sort of asking if they have asthma question. The convention perhaps being that asthmatics are riskier on beta blockers. Now there is heaps of potentially things wrong with this referral, ignoring the contraindication to spirometry with the aortic aneurysm. The best treatment of choice for this person is to lower their blood pressure, so denying beta blockers until the test is done seems overly cautious. And I would question the veracity of the clinical question, as we'll see later when we go through what bronchodilator reversibility testing actually does. Again, they put thanks at the bottom. They're very, very polite. Now, just a side point here for people that do talk to doctors or have the ability to send referrers back. I think in this particular person, it's a safe option to return this referral. maybe directing the referral to a review article on the historic safety of cardioselective beta blockers in airflow obstruction. So note how widely spaced their words are. So graphology is a study of handwriting. As what does wide spacing between words mean? Well, if the words are spaced quite widely, it clearly shows that the writer has developed trust issues, and therefore he is unable to establish, or she is unable to establish, a steady relationship with fellow humans around them. Such writers mostly keep quiet and avoid getting into discussions and arguments. So feel free to send referrals back that have these large spaces, knowing that they shouldn't probably have an argument with the person that sent them. So, what about the results? So what do we hope to see from a bronchodilator response? Or certainly what do the requesters hope to see? Well, I'm pretty sure they hope to see very large responses. But I have to say, it occurs so rarely that when I do get one that looks like this, which is a huge, this is their pre and this is their post. I'm not sure if my mouse is coming out actually. Let me try that again. This is their pre-spirometry and this is their post, and you can see their flow volume loop is nearly normalized. Certainly the results when you look at them are huge changes. That when I get a response like this, if I were to get a response like this, I would run out of the room and show everybody because it's so rare. This is actually a simulated attempt at showing the largest bronchodilator response I ever saw in 15 years. Although I'm sure if you're in ED and trying to do spirometry in someone in the middle of an asthma attack and then after their asthma attack you could see this, why you would do that would be a mystery. My largest response I ever saw was actually when I took the spirometer home to test my annoying housemate who kept me up coughing all night. He had a chest infection and he did not use his inhaled corticosteroids for his asthma. And all his symptoms basically vanished for a few hours after taking salbutamol. It wasn't really rocket science to know he had asthma. There was really no need to do a bronchodilator response, but you can see that he did normalize after, and this is pretty true to what I saw. Well, this is more of a typical bronchodilator response we may see in the laboratories. There's an 84-year-old female. Her pre-bronchodilator spirometry shown here, you can interpret in two ways, according to which guideline you like to use. If you were to use the lower limit normal as cutoffs, certainly, I'll just show you, her ratio being 65 is actually within the confidence intervals. These are NANES 3 predicted. So she does not have airflow obstruction according to, you can't be confident to say that she does, and her FEV1 is also within the confidence intervals. However, if you use the gold guidelines, this is below 70, so she does have airflow obstruction, and having a percent predicted FEV1 of 76 puts her into the moderate airflow obstruction category. Post-bronchodilator, however, she's now normalized, so she does not have airflow obstruction and her FEV1 is still in the normal range, just more within nearer the mean predicted. So the response itself was a 15% increase in FEV1, only 180 milliliters, and we'll go into what that means later on. That in itself a guideline may call insignificant response. So this is an interesting one in terms of interpretation and what you would take from it, because it would definitely split a number of physicians and what they would do. Probably the most pertinent question is whether or not a treatment would get rid of her symptom, rather than trying to put her in a box and then make an algorithm from the box on what to do. Because she could certainly go into a number of boxes, and this is the kind of thing we want to discuss. And what does a BD response really tell you in this one? Post-bronchodilator, certainly she does not have airflow obstruction anyway, but it is a difficult one to interpret, and you will get a different physicians giving you different courses of action from this same data. So why do referrers ask for the bronchodilator response? We've seen some examples from where I am. People must see more value in it. So let's look at some of the guidelines. Everybody loves guidelines, including us respiratory physiologists. So let's start with the 2005 ATS-ERS task force paper. In the interpretation strategy paper, they have a section devoted to the bronchodilator response. Here they define what a currently significant response is, according to the panel that wrote the paper. Now I encourage everyone to read it thoroughly. There is an awful lot of reference caveats to why the bronchodilator response is basically a pretty useless test. And what I'm going to do is go through them and summarize a few of the big ones as I go through the talk, and look at some of the references that they've quoted and some of the more recent publications that came after the 2005 publication. And also let's look at some disease-specific guidelines. What do they say about bronchodilator testing? I should just say the current definition of what a significant response is comes from this paper, and it's a 12% and 200 milliliter change in FEV1 or FVC from their baseline spirometry. They essentially say it has to be this large to rule out the inherent variability of the spirometry, and those numbers are above the threshold of natural variability, but they don't say what the clinical significance of this is. So let's go to a different guideline. So GOLD, which stands for the Global Initiative for Chronic Obstructive Lung Disease. I always wondered why it's called GOLD when it should be GAI-COLD. I guess GOLD sounds a little bit more authoritarian. Anyway, if you go, you can Google this, and they've got a good website, lots of things there. Part of what do they say about the bronchodilator response? Well, so they have a section about the differential of asthma and COPD, and the advice here is equivocal. If you read this, you may get an increase in 12% in FEV1 in asthma, but then you may get it in COPD too. They've neglected to mention the 200 milliliter change in the FVC being meaningful. And what's not in this slide, I'm not showing you, is they do mention a 400 milliliter change in FEV1 as being significant. And in COPD, another test we do in lung function called the diffusion capacity or transfer factor is usually reduced. But that's not something a GP or primary care would have access to. They also say that when trying to diagnose COPD, the spirometry should be post-bronchodilator, which doesn't mean to do reversibility testing. It just says the results to be used should be from the best, the post-bronchodilator. Let's move on to here we have an extract from the 200 pages of the British guidelines on the management of asthma. Here they use 400 milliliters or greater than 400 milliliters improvement in FEV1 as being a meaningful change in FEV1. But it's not just the beta agonist response, but also it could be a response to an inhaled corticosteroid trial, which means doing spirometry much further apart, in at least a couple of weeks. But what's nice from our lung function perspective is over here they actually say you need to have airflow obstruction present at the time of assessment before you do this reversibility. which is actually common sense. But unfortunately, they go and spoil it by doing something quite criminal for an asthma guideline. How they've defined the abnormal spirometry is by having the ratio, the FEV1 FVC ratio, of under 0.7 or 70%. Now, this is an asthma guideline, and the population this applies to is going to be usually much younger than a COPD guideline or population. So if you were to look at the normal range of, say, a 30-year-old female for their spirometry, they should be nowhere near 0.7 or 70% in the ratio. So they're going to have lots of false negatives if you do spirometry and you're using this cutoff. And this is actually, if you've got anything to do with writing for this guideline, this has to be fixed, and the lower limit normal put in. It's not going to be sensitive enough. It's been polluted by a COPD cutoff there, and I would encourage people to use a lower limit normal. Here is another guideline from a fairly recent publication from the New England Journal. Even sports medicine recommends a bronchodilator response for diagnosing asthma, but they do caveat they need abnormal spirometry, and in the small print recommend a fixed ratio of less than 75% for this particular guideline. But interestingly, the bronchodilator response is not apparently good enough evidence if they want to go to the Olympics with asthma treatment. For that, you must have a positive eukaptic voluntary ventilation test, because it is so specific in exercise-induced asthma. So we have a range of disease-specific guidelines that have bronchodilator reversibility testing in there, although they are equivocal about what it does. So we're going to continue and see if it can do any of these things. So can a bronchodilator response actually do what referrers and guidelines suggest it can do? Well, we can go back to our ERS ATS 2005 statement, and it's chock full of disclaimers, like a small print on one of those financial agreements. And let's start with the response itself. What measurement should we choose, and how should we express it? And there are 3 bullet points which I've taken from this statement about this, and you can see them here, and they kind of say a similar thing, and they reference a study, so we'll look at that study next. So we go back to 1992, the year of Whitney Houston's I Will Always Love You, which seemed to spend forever in the charts. A study by Kwanya et al., and I apologize if I say anybody's names incorrectly during this. And I like this study. They very reasonably wanted to know how to use a bronchodilator response to discriminate between different lung diseases and find the best method of expressing change in spirometry that was independent of the initial FEV1. So they took a population of lung disease patients that they'd had for a long time, and they separated them into distinct, in their perspective in 1992, disease categories. Now, I'd just like to point out here that there's a current buzz that people get excited about, is the asthma COPD overlap syndrome. But in 1992, I think they already had this, and they just called it asthmatic bronchitis. Anyway, they looked at the bronchodilator response expressed a number of ways, and you can actually read what they did here. the best likelihood ratio was one that utilized the FEV1 change in the percent predicted, and they found 9% of that, a change of 9% in that particular measure was the most useful. But please note, in the conclusions, there were large overlaps in responses. The paper called it unimodal distribution across the groups. And what do they mean about the likelihood ratio? It comes from specificity and sensitivity, and it means nothing to me straight away. So I looked up how to interpret it. And from a Google search and from a website of stats made easy for people, I found the likelihood ratio of 1.7 would increase the change of probability of the diagnosis by 10%. Now, if you do a test and you're 10% more certain after doing it, if there's a positive response, the positive response being how they've defined it as the percentage change in the percent predicted FEV1, of only increasing it by about 10%, I mean, as far as a test goes, that's not a very good diagnostic test. In fact, it wouldn't meet any proximity to being called a diagnostic test. So it's pretty view, in my opinion, for determining the classification certainly that they made of grouping of those lung diseases. You will always be uncertain no matter what the response. So let's fast forward. Sorry, that was the a 2%. Likelihood ratio of 2, increase it by 15, and 1.7 I just guessed was about 10%. So let's fast forward to more into the present. This is something from CHEST, which was unpublished when I gave this talk. This is a study by Miller, Cooper et al. So they tested the different bronchodilator response criteria against the null hypothesis that a bronchodilator response should show no sex or size bias. So they're trying to reject or nullify the common view of something. And they were trying to determine the best criteria for defining the bronchodilator response. They hypothesized that a clinically important bronchodilator response should be associated with better survival compared in respiratory patients that did not have a bronchodilator response. The hypothesis is based on the premise that people that do have a response or a significant response are more likely to be asthmatic, so are more likely to respond to treatment, asthma being a treatable disease. So they are more likely to be alive in the time frame they've used. So this differs from the study we just looked at, as they didn't classify any diseases in the beginning. So they looked at over 4,000 results of bronchodilator response testing from a database of over 40,000 tests. And they knew whether they were alive on a date afterwards. And they knew several other conditions at the time of the test. For instance, their smoking history, and if they were taking an inhaled corticosteroid or a beta blocker. And just to give an overview of the changes that they saw in FEV1, you can see here there's lots and lots of people that had responses under 400 mils, less than 200 mils certainly, the kind of thing we see all the time. So this is very representative of my experience of bronchodilator testing. There were 444 dead from the 15 years from the test date to the follow-up period. And what they did is they compared many of the previous published suggested bronchodilator response recommendations. This is a great paper to find all the previous recommendations of what a significant bronchodilator response is. I just noticed an error about missing the FVC from the 2005 guidelines. This one here, because it does say an increase of 12% and 200 ml in FVC is also significant. And you'll see a couple of recommendations about using the FEV1 % predicted change are in there. Here they are. FEV1 delta FEV1 predicted. And so what did they find was the best way? Well, just like Quanya, 22 years before this paper, they found the best expression was a change in FEV1 predicted, and found 8 this time to be the magic number in separating out the survival. They found a third of the subjects had a positive bronchodilator response, according to that criteria, when they used 8. And interestingly, if you'd had a response of 8 or more, it was as good as having a response of 14 at being alive 15 years on. The hazard ratio was about 0.5. So basically then, they were half as likely to be dead in the 15 years than the remaining 67% that did not have that magic or significant 8 response. How about when they compared to the other published recommendations? They found that using our current ATS ERS one, using the absolute change and the percent change, was biased, usually to males because they have larger lungs, and to more severe disease. It's worth mentioning though, when it comes to predicting mortality, by far the strongest indicator they found was age, which probably is intuitive. After that, the values were actually all close and ranked as you can see. I just chose the top 4 for on this slide from the paper. Next in both interest was the ratio itself, the FEV1 and FVC ratio. What this study does not do is to tell you who has asthma from a one-off test, and we shall see later maybe the data from a one-off bronchodilator test could be flawed in terms of repeating. I should also say this paper is interesting. I always have trouble finding anything about the role of beta blockers and bronchodilator reversibility testing. And buried in this paper is because they knew the status of the person having the test and the bronchodilator response, they've said being on a beta blocker did not reduce the probability of the subject being found to be reversible by the tested criteria, with a p-value of 0.03 using a one-sided Fisher extraction test. So it appears being on a beta blocker didn't affect the bronchodilator response. So maybe of some use. There's not much about that in the literature I've ever found. So let's move on. I like this study and what it tries to do. This is very much real life of what happens in the lung function lab when you've got people with symptoms and you're trying to ask that question, do they have asthma or not? It's a comparison of the validity of different diagnostic tests in adults with asthma. The study made 3 groups. We've got a normal, healthy control group of just 21. We've got 69 patients with asthma, and they defined asthma as people having a positive methacholine challenge. And people with asthma-like symptoms, which they've called pseudo-asthmatic, were later found on further investigation not to have asthma, and they had things like reflux, which they treated and the symptoms went, or hyperventilation syndrome, So things which could be confused with asthma. And so they exposed these controls, the asthmatics and the pseudo-asthmatics, to various tests and measurements. So they had the methacholine airway responsiveness test, a challenge. They did peak flow diary twice a day for over 2 weeks. They looked at the FEV1 FVC ratio of their spirometry. They looked at the percentage change in FEV1 10 minutes after the administration of a beta-2 agonist, and they looked at eosinophilic counts in blood and induced sputum. Which one of these were going to be the best at picking apart the controls, the asthmatics, and the pseudo-asthmatics, the symptomatic people without asthma. They derived the normal ranges using 95% upper and lower limits from the healthy subject group, and they calculated sensitivity and specificity. And the results of those tests, we're just going to concentrate really on the ones here in the green and red box. And it's a really interesting paper to read. You can see, if we look at the methacholine challenge first of all, just highlight this. As you'd expect, the normal population had basically, this is a positive response if it's on this side of the line, and negative on this side of the line. Just around here is a little bit borderline, but our control group were mainly all negative. As you'd expect, just as their criteria for being asthmatic was having a methacholine challenge positive, the asthmatics responded accordingly, and the majority have quite a strong positive reaction to methacholine and being classified as airway hyperresponsive. And the asthma-like symptom people, most of those had a negative challenge, and a couple had a positive challenge. And that can show you that methacholine does have some false positives. Actually, if you do it on enough normal people, you'll get people that are false positive. Next, we'll look at the sputum eosinophilic counts. The normals had low counts, as you would expect. The range was made from those. Our asthmatics were, a lot of them had a much higher count. I have to reread the paper to know how concurrent the treatment was, because if they were in steroid treatment, you'd expect that to be lower. But it looks like they're not on effective treatment. They certainly have a higher eosinophilic count. And our pseudo-asthmatics were, we've got a lot here with a low count, which would be negative, and then we've got some here which would be positive. It's a marker of inflammation, so you're going to have some of those would later have positive tests for diseases which may have a higher eosinophilic count, but not necessarily the asthma. But what about our bronchodilator response? Well, our normals, for a start, let's see where they put the bar at a 7% increase in FEV1 was classed as positive, so anything over 7%. That's extremely low. That's going to make this very sensitive. It's going to be very easy to cross that, to be honest. And that was from the normal control population. Our asthmatics, look at the scatter. Some of them had a negative response, some of them, less than 0, so they actually went down. Probably half were over the 7%, and a few very positive ones. But a massive scatter across that definition there. And the pseudo-asthmatics really have quite a similar scatter. They're all over the place, but not as scattered. Certainly a few weakly positive ones here and lots of negative ones here. What about the conclusion of what this means? So in the discussions, the authors of this paper, they go on the attack they say the bronchodilator response was not a particularly sensitive marker of asthma, and theirs was consistent with another author whose sensitivity was 37%, and they used only a 8% increase in FEV1 as being a positive response. So that will really mean it's going to make it that's a very small change. So it's going to be overly that increases sensitivity the lower you go, but it will completely ruin any specificity. And what they then say is they obviously had a motive when they made this. Many clinical trials have used a 15% bronchodilator response, it's one of the previous guidelines, as a requirement for entry into drugs trials. Our findings in others suggest that these subjects represent a highly selected subset, and the result of these trials cannot be generalized to a wider population of patients with asthma. I mean, you can see their asthmatics had a large range of responses. This is particularly relevant to some influential trials of long-acting beta agonists, in which the participants were not only highly selected, but particularly likely to respond to the study drug. So that is quite a damning attack on large-scale drug trials which pre-selected their patients to be responding to the study drug. So let's move on. More ATS-ERS statements within the text. There is no consensus about the drug, dose, or mode of administering a bronchodilator in the laboratory. And as you can see, this is from my own workplace before the ultra long-acting ones have come out. There's a few more inhalers to add to this since I made this talk. This is what was available at our district health board, and we can see a plethora of many different types of inhalers, some long-acting, some short, some immune-modifying, anti-inflammatory, some are agonists and some are antagonists, and some are more effective in combination. So really, what is the significance of using one short-acting beta-2 agonist to tell us any information about any of the others? How do we control the baseline? Should everyone be treatment naive, and for how long? If we were really going to test the bronchodilator response, should we use a whole host of different bronchodilators in one hit to know the true change? It's just not standardized at all. And I'd like to thank Ron, who I work with, for he's very good at image manipulation, and he managed to make this slide for me, which is very good. Let's look at the next study. This is called the Eyes-Old study, Calverley et al. They performed an analysis of all the bronchodilator results, the bronchodilator response testing they did during this study. Its IceHold stands for Inhaled Steroids in Obstructive Lung Disease in Europe. And by the way, this is a study that's responsible for the 400 milliliter FEV1 criteria you see quoted in various guidelines around. During this, they measured bronchodilator response 3 times in the same individual, in those that they recruited over a 2-month period, and they did so with a short-acting beta agonist, the SABA, and a short-acting muscarinic receptor antagonist, the SAMA, doing spirometry after each dose. And they used 2 criteria for classifying a bronchodilator response. So this slide summarizes what the study did with the bronchodilator response in 3 visits over the period. In the first visit, this is a pre-bronchodilator FEV1. This is after salbutamol, and this is after ipratropium bromide. Here at visit 1, pre-bronchodilator, and then after ipratropium bromide, look at the response and addition of salbutamol. And on visit 2, pre-bronchodilator, and then no intermediate spirometry. They had both types and the post-bronchial spirometry. Now, the paper has lots about their FVC, which also changed, and there is information in that, but I can't include it in this talk. It will go on too long. So this is one of the most interesting things. So if we follow the path of individual responders and non-responders using either reversibility criteria, an ATS1 or an ERS1, you see a stunning propensity for individuals to change classification on each test. It's a movable feast. So we'll just follow the ATS criteria here. We had 660 people on the study, and the square is a reversible. So of the 660, 275 were reversible initially. Let me just highlight that. And of the ones that were reversible initially, when they were subsequently tested, some of those individuals stayed reversible, but nearly half went to not reversible anymore. And if we come down the other arm to the ones that had no reversibility, of the ones that were retested, suddenly a good proportion of them became reversible. And this is mirrored through the arms. It really is a movable feast. This basically tells us information on the reproducibility of the bronchodilator response. I mean, the response criteria itself of what is a positive and negative is completely arbitrary, as is the response on the day of that individual. So what was the conclusion of this paper? The conclusion is in moderate to severe COPD, which is our population group, and a group we will be doing spirometry on, and lots of people will be doing a BD response on. The bronchodilator responsiveness is a continuous variable, and classifying patients as responders and non-responders can be misleading and does not predict the disease progression. Some of the endpoints measured were their lung function measurements, so they struggled to find any relationship between them and the responses. So this bronchodilator response really is the elephant in the room. And again, thanks to Ron Blazer for making this one. How can you ever trust data from any study that uses a single test of a bronchodilator response and a single agent even? And lots of our evidence we have is used bronchodilator response as an exclusion or inclusion criteria. So was this backed up by other studies? Well, yes, it was reproduced in a study with a very large patient number. This is the Uplift trial, which was looking at tiotropium. In that trial, they did a number of bronchodilator responses on the same individuals throughout it. And they looked at two different criteria of bronchodilator response, A and B. So you can have 12% and 200 mils above the baseline, or you can have a 15% increase. Three criterions and a 10% absolute increase in percent predicted FEV1. That's what we've seen is probably one of the stronger contenders of expressing the change. And their conclusion of comparing those three different criteria and the repeatability of the bronchodilator response in the individuals was the presence of bronchodilator response was a variable at follow-up visits, very similar to what we've just saw. A large proportion of the COPD patients demonstrated significant acute bronchodilator response. The bronchodilator response in those patients is variable over time and differs according to the criteria used. The bronchodilator status at baseline did not predict long-term response to tiotropium, so it was useless at defining which patients would benefit from tiotropium. So not only are the criteria themselves would give you different results, but the individuals would be different at different times tested, and none of them predicted who would benefit from the drug itself. So the ATS-GOS bronchodilator responsiveness statement starts with this passage. Bronchial responsiveness is an integrated physiological response involving airway, epithelium, nerves, mediators, and bronchial smooth muscle, or airway smooth muscle. The within individual difference in response to bronchodilators is variable. The assumption that a single bronchodilator response is adequate to assess both underlying airway responsiveness and the potential for therapeutic benefits is overly simplistic. And we can see where that statement comes from, especially from the Calvary and then the study we just saw. I wanted to try and find a diagram that summed up all the afferents involved in bronchial smooth muscle tone. This is a diagram I found from the Journal of Applied Physiology to try and demonstrate how complicated the system of controlling airway caliber is. So when a person comes in at any one time, there are so many contributors to what their baseline status is, and therefore how a bronchodilator may act upon them on that particular time. I tried to add a few things to jazz it up, because we've got other systems here. And I think you trying to get the message here. It's a complicated system, so why would we expect anything other than a variable response on that particular individual? So how can we change behavior? Well, there are two methods really. You could have a policy based on evidence for your laboratory on when you perform a bronchodilator response. And the second thing is you can write comments. And I certainly feel I can write within limits anything I like within my comments, so long as they're true and supported by evidence. So if you want to use a study to inform a policy on not doing bronchodilator testing on people with normal spirometry, here's a paper from 2012 from Kraper et al. He looked at 7 years of testing people, and I believe it was from 2 laboratories, and he found a positive bronchodilator result using a 12% increase in FEV1 in only 43 out of nearly 1,400 patients in the 7 years. He defined people with normal spirometry using the sensible lower limit normal of the FEV1 FVC ratio. And nearly all of the positive bronchodilator results had an FEV1 FVC in the lower 2 quartile range of that predicted. And most of those were above greater than 61 years old. Of the ones that responded, it's just those few there that he classed as positive responders. But it's interesting, 21 of those 43 had a post-bronchodilator FEV1 FVC less than the lower limit normal after a bronchodilator, but not before. So those patients turned abnormal, or you might want to say they were obstructed after a bronchodilator, which they've called paradoxical bronchial constriction. So you've kind of got a problem with those. So that's one of the things when you're testing essentially normal people and doing something and then they go abnormal, what do you do about those? So it's a nice reference if you want to make a policy and say, look, I'm not going to do a BD response on people with normal spirometry, and here's why. And the next thing you may want to do is your comments. If people read your comments, it can change their behavior. That's a big if, because I know that I could write all sorts, and I'm not sure that the physician that looks at it after actually reads all my comments. I found this presentation online. It's not being published, but I thought it was very interesting. The authors have looked at the communication of how you write about the bronchodilator result in spirometry, and how what you write may change behavior. So they said COPD is a leading cause of death, and just because you don't have a bronchodilator response, it doesn't mean you shouldn't have treatment. And they looked at what people would do with results given to them and then results with comments. So just over 400 primary care staff were giving information during an educational program. They were said a symptomatic smoker whose FEV was 48% predicted, FVC 65% predicted, and a ratio of 60% predicted. And the statement, no bronchodilator response. They then asked those 424, would you treat this patient with bronchodilators? The majority, well, just over half said yes, and just less than half said no. So quite a difference there, or rather not much difference between two different courses of action. They then were given the same information with the additional comment, no immediate bronchodilator response does not preclude treatment with bronchodilators. And they asked the same question, would you treat this patient with bronchodilators? And now, yet a lot more said they would, and still a few would not prescribe bronchodilators. So the extra 6 words in the comments changed the decision making in the majority of the people. So the conclusion really is the language chosen for spirometry reports can significantly influence the person looking at the test result. My big caveat being if they read it, of course. So what do you do if you're still getting, and you will, requests from people who are looking to differentiate asthma and COPD, or diagnose asthma with a one-off beta agonist response? Well, you could put this on the bottom of your report. I don't think it will go down very well. I would say you need to have the referrers know that the bronchodilator response is an arbitrarily defined response, and using the current ERS-ATS definition introduces bias, mainly towards tall men. The bronchodilator response is a continuous variable in individuals, so someone who responds one day may not respond the next day to the arbitrary response. It cannot reliably distinguish between asthma and COPD. Our definitions of those diseases are constantly changing, I shall point out anyway. If there is clinical doubt about an asthma diagnosis, request an airway challenge of some description, mannitol, saline, methacholine. That some are stronger at ruling in and ruling out, and vice versa. But they are much better at elucidating an asthmatic person, and there's published evidence about their sensitivity and specificity. I'm being cheeky here. The people that continuously want this test, I would say they are simply worshipping at the fountain of their own dogma, or they're ticking it because there's a box to tick. So you really, if you can, stop wasting your time doing bronchodilator responsiveness tests, which just give people nearly random numbers, to be honest. For those who are interested, if you want to report the bronchodilator response such as it is in a more meaningful way, this is how you calculate the FEV1% predicted change, which is, if you're going to do it, it's probably the best way to do it. But what the clinical significance of the one-off test means is highly dubious. So anyway, thanks for listening to my talk, and please go to those papers I've put up there and have a read. They're very interesting. There's obviously weaknesses and strengths in them all, and the ATS-ERS paper does have a lot of caveats to why it's not very useful, and I'm always amazed why it's still pushed by anybody as being of particular use, to be honest. Thank you.